Welcome to the Dr. Nol program. In this episode, we bring a very important and mighty subject where the community needs to know about. It's mainly about prostate issues, men's health, and similar subjects. For this episode, we were fortunate to have Dr. Finlay Macneil, who is an Australian urological surgeon. He is also the member of the Urological Board of Urology. Also, he is the immediate chair of training of urology in New South Wales. Dr. Macneil's specialty is mainly operating on kidneys, bladder, and prostate. He also takes a very active role and seriously in teaching this specialty. Welcome, Dr. Macneil, and thank you very much for accepting our invitation.
Thank you, James.
And I have a full confidence that this program is going to be great value to our viewers.
And thank you again.
To start with, there is lots of myth about prostate cancer. And some people are over scared of it. Some people just dismiss it. So how may you dispel the myth about prostate cancer?
Yeah. Well, if you've got a day or two, we could dispel most of the myths. In a short time, there are a lot of myths, I'll say, promulgated, put about by people, perhaps for less than scrupulous reasons, trying to sell something to the public. But in reality, it is a very, very common cancer. It is the most common cancer diagnosed in men, other than superficial skin cancers, at 30% of cancers. It's the second most common cause of cancer death in men as well. 13% of cancer deaths in men are due to prostate cancer. But of all the men with prostate cancer, most of them will die with it and not of it. And you're currently 5 times more likely to die with it than of it. And so, although we need to be aware of this and we need to try to prevent the burden of mortality and indeed morbidity of men dying of the cancer, we've also got to avoid overdiagnosing it and making the population over-worried about it. So we, the Urological Society of Australia and New Zealand, as well as the Prostate Cancer Foundation of Australia, have been trying to promote a responsible attitude to both diagnosis and treatment of prostate cancer, so that men and their partners are informed about the disease and can make informed decisions about what they should be doing.
Just to start with, how do you diagnose prostate cancer?
Well, here we get to one of those myths. So often men come to me, they come to see me and they sit in the chair and I say, why are you here? And indeed the real reason they're here is usually sitting in the chair next to them, that's their partner. But the common thing that they're told is, you've got an enlarged prostate. And they read that as code for, you've got prostate cancer. But diagnosis actually involves taking tiny little pieces out of the prostate for examination under a microscope. And there are many, many different ways of doing that. And we can come to that later. But nearly all of them involve some risk. So, of course, we then say, well, should you be taking these biopsies? Because if I say to a man, I take a biopsy from a man and say, you've got prostate cancer, and he says, so what? Then of course I'm not going to do anything about it. There's no point in the risks involved with the biopsy. Now the biopsy does carry risks. All men get bleeding afterwards, blood in the urine, the semen, the bowels, although not in the bowel with one of the routes that's now being used more and more often. The bleeding is generally a nuisance but seldom does any harm. But there is also a risk of infection from this biopsy, particularly with the commonly used route of transrectal ultrasound-guided biopsy. And so what happens is that in about between 2 and 5% of men, germs go from the prostate or into the prostate and then from there into the bloodstream and cause an infection of the blood. And that is a very serious condition indeed. And with the rise of the multi-resistant organisms, that's germs that are resistant to nearly all of our antibiotics, these infections are now really, really worrying us because we're going to see men with infections that we have great difficulty treating or can't treat at all. So before we take a biopsy, we say, hang on a minute, do we really want to know the answer to this? But you don't take a biopsy as a method of saying, this man might have prostate cancer. And what we have been doing is using a variety of screening tests. Now the common one that everybody knows about, of course, is called the PSA, which stands for prostate specific antigen. But in addition to that, we need to be doing digital rectal examinations on these patients as well, because sometimes we can feel the cancers that don't show up with the PSA.
So is this usually done when they come to you or already being done at their GP level?
Frequently, the men have already had a PSA done before they come to see me, done by their GP, and sometimes they've also had the digital rectal examination. What that does is tells us the odds of finding a cancer in the prostate, the probability of that. Now, this is a little bit like knowing the odds at the races, and for those of you who spend time in the races, you know that you can know the odds of a horse winning, but you've got no idea which one is going to win. All it tells you is how likely it is to find a cancer.
But I'm expecting, for example, or suspicion is the higher the PSA, it means the more likelihood, is it?
Yeah, the higher the probability. So PSA became commercially available in 1985. So this, and I'm not sure whether I mentioned it, stands for prostate specific antigen. And it's a blood test, just a simple blood test. And it is very, very accurate on that test. But what it, as I've said, doesn't tell you is whether or not we'll find a cancer. And it's been used for many years now as a screening test. But until recently, we really didn't have any large-scale studies on its efficacy, as that is how good it is as a screening test. The ideal screening test costs nothing, finds all the cancers that we want to find, finds only the cancers that we can treat, and is looking for a disease where treatment will make a difference, that is, get people to live longer. And of course, there is no screening test that does that. And the PSA test is imperfect. It is, you can set by, as you referred to, higher and lower levels, you can set the level too high and then you'll miss cancers that you should be finding and treating in the group that you don't take a biopsy from. Or if you set the cutoff level too low, then you'll be subjecting men to biopsy who probably don't need that biopsy, or definitely don't need that biopsy, they don't have the cancer.
So
that's a trade-off. So there are a number of ways of making the PSA more accurate, and one of the best is to actually take the PSA as a serial observation, that is, to do repeated PSAs over time, and we're talking years. And by looking at the change in the PSA, we can be much more accurate about who we need to take biopsies from. Recently, there's also been a lot of interest in the use of MRI to diagnose prostate cancer. And I need to say right at the outset, MRI is not a screening tool. Despite what you might have heard, this is another myth that I'm afraid has spread a little bit in the electronic media. It is not a screening tool. It is a tool for deciding whether there is a cancer in the prostate which would worry us. So that if we can see a cancer with certain characteristics on MRI in the prostate, that cancer is highly likely to be something that we would be concerned about, so a high-grade cancer which needs treatment. And implicit in that statement, of course, is that there are lower-grade cancers which don't need immediate treatment and can be observed closely. So that's the real use of the MRI. It can also be used later on in deciding which treatment is appropriate for certain men and so on. But it is not a screening tool. So at the moment we're still stuck with the PSA testing as the screening tool. I should actually mention also, when I was talking about the MRI thing, one of our things that we can be very proud of in Australia is that the world's the first truly groundbreaking research on the use of MRI in diagnosing prostate cancer was done by a group in Brisbane led by a man called Les Thompson. And that was published earlier this year, that research. And it is really very good research indeed, and it shows just how useful MRI is in picking these high-grade cancers. It is also, the other consequence of this research is that it enables us to take a fewer number of biopsies if you have the setup to use the MRI to guide where that biopsy is taken from. Unfortunately, it's also expensive.
Very expensive.
The other method that we use, coming back to what you said, how do you diagnose it, is to use this thing here attached to an ultrasound machine in the rectum to take pictures of the prostate, very accurate pictures with an ultrasound probe.
Dr. Macneil, we're going to leave this for the after break.
Yes.
And before we go to the break, I have a question. There is a myth that PSA varies based on sexual activities on the day before or same day. Yeah. Can you shed some light on that?
Well, the short answer is it doesn't vary enough to put you from one group into another group. There is a small variation related to the time of abstinence or when you last ejaculated, last had sex. But it doesn't put you out of one group into another group to say, oh gee, look at that. That man may well have a cancer based on their sexual activity in the recent past. So as a general rule, yes, it's better to have the blood sample taken after at least 2 days of abstinence, if you can manage that. But it's not something that you should be unduly concerned about.
Okay. Now, what about medication like Viagra people take and things? Would they have any impact?
There are medications which have an impact. The drugs that you refer to, Viagra and Cialis and Levitra, have very little effect on the PSA level and indeed also on the risk of having a prostate cancer. There are drugs which lower the PSA level. And a drug which is commonly used in benign disease to improve both urinary symptoms and the risk of not being able to pee at all, which is called acute retention, and indeed the risk of having an operation on your prostate, so for benign disease. Proper name for the drug is dutasteride, and it is on the PBS, that is the pharmaceutical scheme here in Australia, in combination with a second drug, marketed as Duodart. And that drug over 12 months will reduce to half the PSA level when you take the blood sample, so that it can lead to false reassurance that there's no prostate cancer or no increased risk of prostate cancer in the men who are taking that drug. Now, nearly everybody prescribing that drug are also aware of that effect of dutasteride. In addition to that, there are some herbal complementary medicines which also reduce the PSA level. Now, because this is an unregulated industry, we are not as sure about the exact effects of those, but in general, any of the herbal preparations which are what we call phytoestrogenic, that is, they are plant equivalents of estrogen, will reduce the PSA level by a variable level. As I said, it's not the PSA that's the harm, it's the fact that the PSA is, the raised PSA is alerting us to the possibility that there is a cancer there in the prostate. And then, as I said, the next question is it a cancer that we want to treat? Now, we, I think, are going to this after the break, but we do need to talk about who would you consider taking a PSA on, and I'll leave you to consider that one over the break.
Thank you very much, Dr. Macneil. And as we said, we'll have a short break and we'll get back soon. Thank you.